From the Baker Institute for Public Policy at Rice University in Houston, Texas, this is Baker Briefing. I'm Ambassador David Satterfield. Baker Briefing tackles the most critical foreign and domestic policy issues of the day. Each episode is recorded in front of a live audience at Rice University in Houston, Texas. Today's topic, maternal mortality in Texas. Maternal health is widely seen as a key indicator of a society's overall well-being. But two new reports out of Texas paint a concerning picture. America has the worst maternal death rate of any developed nation, and Texas ranks 8th as the worst state in the nation for maternal mortality. The Texas State Maternal Mortality and Morbidity Review Committee report, released in December 2022, found that roughly 90% of deaths between 2018 and 2020 were preventable. Another report, released this past January from researchers at UT Austin, looked at nationwide trends during the pandemic. They found that deaths among pregnant women and new mothers rose sharply during the pandemic. For today's discussion, I'm pleased to welcome three talented scholars who work here at the Baker Institute: Dr. Rola El-Serag, Ms. Elena Marks, and Dr. McLean Sampson. I'm going to start, Rola, with you. What do we mean when we talk about maternal mortality? Why does the U.S. have the worst maternal death rate of any wealthy nation?
Thank you. Maternal mortality refers to the death of a woman while pregnant or shortly after delivery, and it's related to either the pregnancy or aggravated by the pregnancy. Now, we also talk about pregnancy-related deaths, and those are deaths that are associated with pregnancy that can occur all the way up to 1 year after delivery, which people don't really realize, and which we will be discussing in a bit, why the issue of expanding postpartum care and expanding Medicaid is so important because of deaths that can occur up to 1 year after delivery. Pregnancy-related deaths, over 52% of deaths occur after delivery, and so that is a significant issue. And the CDC tragically reports about 700 maternal deaths per year. In fact, maternal mortality is the 6th most common cause of death in women of reproductive age group. The Texas Maternal Mortality Committee, since 2013, has been looking at the top causes in maternal mortality. And of note, in the top 6, the second most common cause is mental health, which most people don't think about as a cause of maternal mortality. And the 4th cause is injury, too, which is an important fact to consider. As far as violence, one of the recent reports from the Maternal Mortality Committee reported that 27% of pregnancy-related deaths are due to violence, which is a shocking statistic in my mind, and the majority of these injuries were due to firearms. Now, why does the U.S. have the most maternal deaths? That's a very complex question. First, the U.S. has significantly higher maternal mortality rates than other countries. So the second highest mortality rate would be in France when we talk about developed countries. And so the US has a 17.4% versus 8% in France. So it's significantly higher in the US. I think there are several major reasons why the mortality rate is higher. The first has to do with physiology and environment. American women tend to have more chronic illnesses. Obesity is more common in America. About 20% of maternal deaths are related to obesity. That leads to diabetes, high blood pressure, heart disease. All of those increase risk. And then they're also a reflection of just an unhealthier lifestyle in the United States compared to other developed countries. American women also have a higher mental health burden. And as I mentioned, the second cause of maternal deaths in Texas is mental health, so that plays a key role. We have higher rates of violence. Again, I mentioned 27% of maternal deaths were related to violence. And then from a socioeconomic standpoint, we are very different than other developed countries. First, American women tend to struggle more or face barriers with regards to access comprehensive health care and deal with issues related to cost of delivery and obtaining care. In addition to that, we also have significantly more racial disparities, which plays a significant role here, and we'll talk about shortly. The last two major reasons: we have a very high rate of unintended pregnancies. Texas has the highest. Over 50% of women are getting pregnant without any intention, which means women who shouldn't be getting pregnant are getting pregnant, and that increases maternal mortality. And then finally, our healthcare model is different than other developed countries. First of all, the U.S. has significant workforce shortages. We have shortages in obstetricians and gynecologists, midwives, and primary care. We have maternity deserts across the United States where women don't have access to maternity services. And some of these gaps are 2 to 6 times greater than other developed nations. In addition, our system is different because we rely less on midwives and primary care. And the data shows us that we, in many cases, have better outcomes when maternity care is provided by primary care and midwives, especially when it comes to psychosocial outcomes and efficient use of resources. So things like access to home visits and paid leave, for example, are very different in our country.
Dr. Sampson, before I ask you to dissect the outcome of the Texas state reporting on the situation here, I've got a question for you about methodology. When one says Texas is the 8th worst state in the United States in terms of maternal mortality rates, are these truly comparing apples and apples, like socioeconomic demographics with like socioeconomic demographics? Texas is a very large state with an extremely diverse population. Other states are not. They're more homogeneous. Others have problems similar to ours, but not on the scale. How do these comparative rates 1 through 50 derive?
Well, thanks for that question. Yes, in all of the studies, when they look at mortality and severe maternal morbidity, which happens an even more alarming rate, there's about 700 deaths per year, about 50 to 60,000 severe maternal morbidity, meaning a lifelong consequence from the birth. When they're doing these kind of analyses, and in the state analyses they showed their methodology, they do control for demographics, because that's something I always bring up being a Texan, is that this is an enormous state. We have one of the highest rates of uninsured. We have a lot of different kind of demographics than other states. So when we're comparing, we really need to control for things like income, immigration, all kinds of things. So it is important to know that even across every study that they do, no matter when they control for race, for age, payer status, we still have the highest rate of any industrialized country.
That's extremely interesting, because at a later point in this discussion, I'm going to bring it around. If you're truly comparing apples to apples, similar socioeconomic circumstances to similar circumstances, other states are doing better with the same demographics as Texas. And I want to get to the why. What's different here as opposed to those other states with the same or very similar characteristics? But I'd like to ask you, can you describe what did this Texas statewide analysis show in terms of the trend lines?
So this very disturbing trend of, when we say racial disparities, to put a fine point on that, Black women are dying at least twice the rate of their white counterparts. This is even when we control for socioeconomics. You'll often run into arguments about, well, you know, that's also a group that has a high poverty rate. It doesn't matter the economics, it doesn't matter the education. Black women are dying at alarmingly higher rates, and their morbidity rates are higher. The report also showed that there was an increase in Hispanic women deaths during COVID. We think a lot of that is COVID related. So what it suggests is that this trend is persisting, not only of the high rates, but of the massive racial disparities and a lot of these non-medical drivers that I'm sure Elena will bring up, which is also something that makes unique to Texas.
So before we turn to Ms. Marks, merely emerging from the pandemic is not going to significantly change these trend lines, correct?
That's correct. It was there before the pandemic, it got worse, and now we're seeing it play out.
Ms. Marks, given this, where do we go?
The biggest, easiest fix that won't fix everything, but will fix a lot of it, is for Texas to expand coverage so that these women have access to comprehensive health care before, during, and after their pregnancy. And in fact, that is the #1 recommendation of this committee. We have the highest rate of uninsured people in the country. And when you are not insured, you don't have access to health care that you need. And it's not just health care, but once you are part of a health care delivery system, and you're part of a health plan, you have access to other services as well that can help you get through a pregnancy, can help you prepare for a pregnancy by being healthy on the front end, being intentional about wanting to get pregnant. We've had an abysmal record in Texas over the last decade relating to family planning. It's just been slashed. The entire infrastructure was gutted. And so you have, as one of my co-panelists said, highest rate in the country of unintended pregnancy. So people don't want to be pregnant, their bodies aren't prepared to be pregnant, they're not taking care of themselves in a way to be pregnant. They get a little bit of coverage for a brief period of time while they're pregnant and for just 60 days thereafter. And those are lost opportunities to help these women.
Why is this maternal mortality worsening in Texas, and why is it disproportionately affecting women of color? Are the trends in Texas consistent with what's happening in other states?
Two things. Number one does have to do with coverage. The states that are worse than us also have poor rates of coverage, meaning that they haven't expanded Medicaid postpartum in some cases, but even for all people so that women who are not yet pregnant can get into care. That's one thing they're doing. Another thing that some states are doing is that they have taken this data seriously, and this data has been around in Texas for a decade. These reports have been coming out for a decade, and other states have decided that they will actually do something about it. And what some of them have done does relate to health care. They've expanded Medicaid or expanded it postpartum or have done other things within the health care delivery system. But the ones that are doing the best job at it are taking a more holistic approach and recognizing that the medical care is a really important component for pregnancy, probably the most important component. But there are all these other contributing factors that leave women at greater risk. One of the panelists talked about obesity. The causes of obesity don't have anything to do with medicine. They have to do with diet and exercise, and those are things that you can improve outside of the medical system. The mental health being such a large cause, interpersonal violence being such a significant factor. Those are things that if a state is serious about reducing maternal morbidity and mortality, it develops programs that help these women in all sorts of ways in addition to the medical. So again, it's get them covered so that they have access to the health care delivery system, but also take it seriously and build holistic programs that recognize all of the various causes that make them at greater risk for an adverse outcome.
Why is Medicaid expansion an effective policy response? How will it make an impact?
There are two parts. The first, the big Medicaid expansion, is the opportunity that was given to all states under the Affordable Care Act to expand Medicaid, which currently only covers people who are very, very poor. And so people who are below 100% of the poverty level in Texas do not have access to affordable health care. And the solution for that under the ACA was to expand Medicaid with the federal government paying 90% of the cost of that so that those women, pregnant or not, and men too, pregnant or not, would be covered. And that would give them access to comprehensive reproductive care. That would help on the front end because that means you would have women who had access to contraceptives and access to other services that help them become healthy enough to have a healthy pregnancy. The other opportunity that Texas has not taken that has been offered by the federal government and really encouraged is for all pregnant women, because you do qualify for Medicaid if you are poor and pregnant while you're pregnant. The federal government has been asking states to increase their coverage to 12 months after the woman delivers and not just 2 months. And so either of those would be immensely helpful in Texas.
If I could ask from a detached analytical standpoint, many years after the introduction of what has been referred to as Obamacare and the end of that administration, what are the current arguments against the expansion?
In Texas today, they are purely ideological. For a long time, there was uncertainty about whether the law would last past that. For a long time, there was uncertainty about the economic and health impact of other states. Tons of data now showing that the states that have expanded Medicaid have actually benefited financially in addition to the positive health outcomes. In my opinion, the only existing barrier is ideological.
And what is that ideological barrier?
That poor people shouldn't get something for nothing, that they don't deserve it.
As a medical care administrative professional, what's the cost to the state of Texas of not providing this expanded care?
I wish I had the report sitting right in front of me, but we're talking about billions of dollars a year in federal funds that would have flowed into the state and that would have gone into healthcare providers and others who work with the people who would have been given access to care, and that would have increased the coffers of state and local governments. But the total is estimated to be, I think it's about $5 billion per year of benefit, lost money.
Of benefit. I'd like to ask you quickly for your thoughts. With the Dobbs decision from the Supreme Court, do we have enough information in the collective to determine yet what the impact is or is not of that decision on at least mortality, if not long-term morbidity?
I'll take that question. First of all, the effort to ban abortion in the state of Texas has been ongoing for over 20 years. So I think it's important to consider what's happened before the Dobbs decision and the impact that that's had on maternal mortality. So for example, if you look at the defunding, this was mentioned earlier, but the defunding of Planned Parenthood in 2011, access to family planning services was cut significantly. What that means is that a lot of women who shouldn't be getting pregnant, are not prepared for pregnancy, are getting pregnant, which increases maternal mortality. Now, this was studied by UT Austin, published in the New England Journal of Medicine, where they looked at the direct impact of the defunding of Planned Parenthood, and they found that, especially with the long-acting contraceptives, which are the most effective ones, that there was a reduction in 2016, there was a reduction in the number of prescriptions for those contraceptives and an increase in Medicaid pregnancies. So what we do know is that increase will be associated with maternal mortality. Now, the Biden administration also, in December of this last year, made an announcement that the Dobbs decision has a devastating impact on maternal mortality, and this is based on this Commonwealth Fund study that just came back, and that showed in 2020 that the maternal mortality rates were 62% higher in states that ban or restrict abortions. And they cited several reasons for this. First, in the restrictive states, women have less access to affordable health care. Again, we're talking about the issue of access, and less access to maternity health care providers. They also found that these states had significantly worse shortages in maternity care providers and more of these maternity deserts. And what we are seeing is that the Dobbs decision is driving our maternity health providers out of these states. In the medical education side, I can say we are anticipating, for example, that residents are going to be applying less and less, for example, to those states where there's restrictions on abortion. And there have been several other studies that have shown this. Now, why would this be the case? Because if women do not have the option of abortion, they're basically being exposed to their existing risks of maternal deaths. And like I mentioned, when more than 50% of pregnancies are unplanned, some of those risks can be very significant.
Very good. Could I ask you each for a concluding word, starting with you, Lena?
Texas is a wealthy state, and we can do better. And we have all the data we need to know what the problem is, and we have examples from across the country about what solutions can be. We just have to make up our minds to do it.
Does public polling in Texas validate that Texans want this?
Actually, the Episcopal Health Foundation released some public polling yesterday that showed that maternal mortality, dealing with maternal mortality, is a favored cause by the majority of Texans.
So in addition to my role here, I also oversee a large community-embedded program that seeks to reduce infant and maternal mortality. It's called Healthy Start. And I can tell you that what we do there is an example of what can work, where we work with the community. It's taken us a long time to get their trust. There's a lot of mistrust, and we help to synergize by influencing their voice into the medical community and the funders. And if those three groups can talk, the community's affected, the community of medical providers and funders, we see change. It starts to happen because this has to be a multi-level and a multi-system type of change effort.
Maternal mortality crises is a crisis of epic proportion, especially in the state of Texas, and we all need to be very concerned about this. This is not just an issue of pregnant women, because maternal mortality, as was mentioned earlier, is an indicator of overall wellness of our society. So it's a red flag, it's an alarm signal to us. And I think that in order to address this significant crises, we need to use an evidence-based approach where data is driving our policy, and it must require the collaboration between our federal government, our state governments, local governments, and science in order to tackle.
And if such an approach were to be taken, would the medical professional caregiving community support it?
That's what we see. The medical providers are asking, they're begging for help. And I've met so many providers who are ready, willing, and able to serve, but there's a lot of mistrust, like I said, of engaging in the services. Even sometimes when you have access, you might have something you can offer, but they've had bad experiences with it, so they don't utilize it. But what I see is medical professionals want to do their job, which is to help people be healthy, and they want to be able to do it effectively. So I've heard a lot of buy-in at the
And
local
it can
level.
only be done at the level of the government, because a lot of the changes that need to occur are socioeconomic and structural.
Right, mostly social.
And that can't be done by medical professionals.
But there is not a structured opposition from the medical professions to the expansion of healthcare benefits.
No.
Not that I've
There's
seen.
The
consensus.
hospitals and the doctors all support it, as did the business community, Medicaid expansion.
Very good. Thank you all very much.
Thank you.
Thank you.
Baker Briefing is brought to you by the team at Rice University's Baker Institute for Public Policy. This episode was produced by Victoria Jupp and Shannon Moriarty. AV production was conducted by Daniel Padilla and Kevin Young. Many thanks to the Baker Institute production interns who assisted with this episode, Maya Adhikari and Sarah Davidson. The Baker Institute for Public Policy provides meaningful policy analysis on the most critical challenges facing Texas, the United States, and the world. It is a nonprofit, nonpartisan policy research organization based at Rice University in Houston, Texas. To learn more, including how you can attend a live podcast recording on the campus of Rice University, visit us at bakerinstitute.org. Thank you for listening.